welcome everybody. I wanted to welcome you as Chair of SLAM, I'm Jane Bailey, to our first inaugural lecture of the Maudsley Lectures. I think, I'm very excited and honoured to be welcoming you all, all of you here and all of everybody online. I think you'll hear more from Ade, who is the inspiration behind this, in a second. But I think we started off as South London the Maudsley at the Royal Bethlem in 1247. So there's a huge history in this organisation, and I think we have always driven innovation in how we treat mental health and how mental health is delivered. But for me, we can't do that without research and information. And I think what makes us very special is that combined relationship between the NHS Trust and the IOPPN and King's College. And I think that's the really exciting thing, I think, about both organisations in a way, that we can do things for our mental health patients and for the communities we serve that no other organisations can do together. I think there's a lot of unmet need in mental health, and together we can look at how we change that, both in terms of therapies or therapeutic interventions, but also in terms of models of care, about how we can really change that. But I guess for me, part of this evening is, and one of the things that the organisations can bring, is challenging us and making us think differently. And I think that's whether you're an academic or you're a clinical person, hearing new and different ideas and world-leading experts can make us all do our jobs differently. And that is what I feel passionate about, as all kind of improving, using the immense expertise we have around us to just really drive outstanding care. And I guess coming into this role, that is one of my passions. So we're very honoured tonight to have an expert that sits between both organisations and a professor. I'm going to leave Ade to introduce them. This was Ade's idea, and I think it's fantastic, and I'm really pleased to see you are all here, and I think it's a start of a very exciting lecture series. So Ade, over to you.
Thank you, Jen. Thank you, everyone, for coming tonight. I'm really excited. This is our first one, and it tells you about, when you have corridor conversation with Derek, what can happen in the space of a few months. And there you go, Derek, we're here. And I'm told that we have a number of people joining us from across the UK and Europe. And actually, Chris was telling me we have guests from New Delhi, Pretoria, Melbourne, Pasadena, and Tokyo. So, and they're actually watching, and they're part of this inaugural lecture called Maudsley Talks. It's not going to be like TED Talks where you wear jeans and try to move around on stage. But part of the reason we're able to welcome so many international guests today is the rich history that our trust holds. But that is only a small part of it. The reason why so many people join us is part of the DNA of the two organizations. That commitment to improving patient care and the passion for greater understanding through research and innovation to make a difference in the lives of our patients and service users. We have a wealth of amazing talents, colleagues who are doing incredible stuff, and quite a number of you are sitting in this audience tonight, and that is why we're here tonight. So I thank each one of you. You have been a contributor to that history, to that legacy, to forging ahead to make sure that this organization and the two institutions work together. And for some of you, you will have seen that I keep saying the two organizations forms the best in Western Europe. And I believe that. And I don't know if you believe that too? Yeah. Yes? So to share with you and the global audience some of the world-leading mental health insights and research that is happening right here. So Maudsley Talks bring together all clinicians, researchers, academics, and thought leaders to engage audiences across the NHS, the academia, policy making groups, and the wider public. It will inform, educate, and ultimately help to turn the trust-rich source of research, insight, and innovation into impactful changes to how mental health care is provided in the UK and beyond. One man who has been doing this for some time is our special guest for this evening. And I'm going to try and read what I have. He's a professor of biological psychiatry and at King's College London, and a consultant perinatal psychiatrist at South London and Maudsley here. He's passionate about education, advocacy, and public engagement, and also driving mental health over the number of years, as well as being the chair of mental health charity, and some of you will have seen the leaflet being handed over to you this morning as I was coming in. I must have got 3 of us. Please join me in welcoming Professor Carmine Pariante.
Well, thank you, Ada, and thank you, Jane, for your for introducing, starting this evening, and Derek for the organization and for thinking of me as the person that should give the first Maudsley talks. I've been working at the Institute of Psychiatry and at the Maudsley for 29 years. So I really kind of feel that this is my home. And the work that we'll present tonight is one of the main, certainly one of the main area of research and clinical interest for me over the last few years, which is perinatal mental health. And I will talk in particular about how, by helping women who are unwell today, either in pregnancy or in the immediate postpartum period, we're also helping the next generation. And this is, of course, kind of makes us having an impact not only on the present, but also in the future. I'm on social media, for those of you who are, and obviously there's a hashtag for Maudsley Talks, so feel free to tag me if you're going to put any pictures or videos of me. Don't say anything bad, please. Only nice comments. So I think we all wish, as kind of, I guess, general public people, mental health practitioners and clinicians, we all wish that mental health in the perinatal period would always be like this, like happy, close relationship, a happy interaction. But we know, unfortunately, that this is not always the case. And I'm going to show you some data today on my work that kind of spans pregnancy and the postpartum period, and both understanding mechanisms, biological, clinical, and psychosocial mechanisms, and potential therapeutic intervention. Before I do that, I just want to say a couple of things about me. Some of them have been already said by Ade. So I'm the chair of the Psychiatry Research Trust. This is a small charity that's been associated with the Institute and the Maudsley for the last 30 years. And we support both young physicians, young mental health practitioners, and early career researchers. So some of you had either had the money from the PRT or will get the money from the PRT. So that's the time that you should give the money to the PRT. So if you have a leaflet or if you are online following this, please do donate. The money goes straight back into the system, you being the system. I'm also the editor of a digital mental health magazine called Inspire the Mind. And for those of you who are not aware of it, I would really recommend, including our friends online, I would really recommend to go and visit it. It's an asset for King's College London and the Maudsley. It's an opportunity for clinicians, mental health practitioners, young scientists to write about their clinical activity, their research, and also for people with lived experience that we always invite to write about usually kind of important topics and how they kind of their own personal experience interface with the current debate in society around mental health. And you can search for topics using the search function, and if you look at the last few blogs, for example, if you search for perinatal, we have more than 100 blogs written on perinatal mental health. These are just the recent one. It spans, as you can see, from research to recent movie to the clinical needs, arts and creativity, and so on. So 2 roles that are, if you like, so important for me at this stage of my career. But of course, my career, as I said, started many, many years ago here at the Maudsley, and that's me. I don't know if you can recognize me. This is the famous picture of the Maudsley that the Maudsley trainee would take on the first day of their training when they started. And you can see the small number that we were. Professor James McCabe was sitting there. You can see standing next to me. We all both look exactly the same. And this picture is not only to kind of show how long I've been here and how fond I am, of course, of this institution. Or these institutions, although I still consider them one single institution, one brain, one heart, full of passion and people that are just so committed to knowledge, to care, to advocacy, to public engagement. But also because that's really where my journey as a perinatal psychiatrist started. Because it was during the training that I did a 6 months rotation with Professor Chani Kumar. Now, some of you, well, hopefully all of you will know Professor Chani Kumar, who left us really too soon in 2000. He was, at that time, the clinical and academic lead for perinatal mental health. He was then, and is considered today still, world leaders in perinatal mental health. And he's created an amazing teams, a mother and baby unit, and a kind of community team, a series of community teams that really, I think, has been a model for all of the UK perinatal mental health. And that's also when my friendship with Trudy Senaviratne, who is sitting there, started. Trudy was my SPR at that time, and she trained me for the part 1 and the part 2 of the Royal College of Psychiatry exam. And I think that she and Chani were together instrumental in developing the passion in me for perinatal mental health. And so when years later the job came up that had kind of to lead the perinatal mental health research, in addition to kind of participate in the clinical activity, I was so delighted that I was able to apply. And of course, I soon noticed that it took 5 consultants to do the job that Chani Kumar was doing all on his own. So yeah, you see how some people just manage to deliver work in a way that is so personal to them. And there are so many people like him. There have been so many people like him. There still are people like him at the Maudsley and at the Institute. Now, in terms of perinatal mental health, if you just talk around the table at the pub about perinatal mental health, everybody think about postnatal depression. That's what people know, that's what people recognize. It's a term that is used routinely, if you like, in a conversation on mental health. However, one of the main messages of my talk today, and certainly a lot of the research that I've been doing, is the fact that depression, mental health problems in general, and depression in particular, is as common, if not more common, in pregnancy than postnatally. And a lot of the women that the clinical services, and I know there's many of you, I can see people from the clinical services, from the perinatal clinical services here. A lot of the women that we see in the clinical services in the postnatal period are women that actually have been suffering already since pregnancy, and they only come to the attention of the clinical services in the postpartum period because perhaps that's the time that they cannot cope anymore, that's the time that they understand they really need help. Maybe they couldn't approach the services before because they felt that, they felt there was not the right things to do. They were afraid of judgment or stigma. But depression in pregnancy is as common, if not more common, than postnatal depression. And for me, both as a clinician but as a scientist, it's important to remember that depression, that the pregnancy is the time that actually there is a direct biological communication between the mother and the baby. There's a true exchange of biological signal through the placenta, through kind of, you know, the exchange of nutrients, exchange of constant biological signals, especially around circulating molecules in the blood that signal stress. And so perhaps one of the findings that I will show tonight is that across a lot of outcomes, being it biological, being it psychosocial and clinical, depression in pregnancy actually have a strongest impact than postnatal depression, because there's something about mental health difficulties at the time that translate into an effect in the infant because of the literally biological connection between the two. And the second point that I think I want to make, and I'll show you some data on this, is the fact that perinatal depression, perinatal mental health problem in particular, in general, but perinatal depression in particular, is not just about that mother. And as I've said, you know, it's definitely about the mothers, the family, and also the next generation, the infant, and the potential trajectory that a difficult pregnancy or a difficult postnatal period can create in the infant when it becomes a child or when it becomes a young adult, with potential trajectory to an increased risk of mental health problems. And then potentially that person will, you know, be a father or be a mother and maybe transmit some of this risk to the next generation yet. So this is a unique opportunity to change the trajectory at a kind of systemic level, not only that person that we're helping person down the line from that person. Now, I'm going to show you some data. Some of that is biological, some of that is clinical, as I said, and all of this has been published, and is part of a study that we conducted all here at the Maudsley Hospital, and women that were recruited from the clinical services at the Maudsley. A study that we call the Psychiatry Research and Motherhood Depression, or PRAM-D. There was also a parallel study on psychiatry research and motherhood in psychosis, that for women with postpartum psychosis and bipolar disorder, that was also conducted in the perinatal services here and other perinatal services in London, which is led by Professor Paola Dazzan, and I'm not going to present the data because that's her work, but it was quite a lot of kind of a cohesive program of research that started almost kind of 15 years ago, and now not only all the data have been published, we're doing follow-up of the kids. So it's a study on depression in pregnancy. The women that we recruited were depressed in pregnancy, or they were pregnant, but they were not depressed, so we call it healthy control, but they were all pregnant. We also had a second paper on a second group of women that were considered a risk of mental health problem because they had a history of major depression, but they were not depressed during pregnancy. And the reason why we had this third group is because we were trying to disentangle how much of the risk, the biological changes and the clinical changes that we see in the mothers, but also in the baby, are due to, if you like, a genetic predisposition or a lifetime predisposition of mental health problems, and how much is due to the actual mental health difficulties at that time, the pregnancy or the postnatal time. So I will start with cortisol. For those of you who know a little bit about my research, you know that cortisol is one of the preferred things that I like to measure in any possible way. Is the main stress hormones. Is secreted by the adrenal gland that sits on top of our kidneys, and is clearly elevated in every situation of stress. From milder to more severe, from chronic to acute, cortisol, it would signal a situation of stress. And we know that in depression, as in other mental health disorders, outside pregnancy, cortisol levels tends to be elevated, possibly as a part of the pathogenetic mechanism, possibly as a consequence of the arousal and the distress of actually having the symptoms. And we found exactly the same in the women with depression. So if you just look at the top line, that dotted line, which are the case of the women who were depressed in pregnancy, you can see that compared to women that were not depressed, that were also pregnant but not depressed, which is the continuous line, the level of cortisol are higher both in the morning, so the awakening time, and in the evening at 8 p.m. And this higher level of cortisol is a hallmark, if you like, of quite reproducible biological findings in depression. I think what is interesting about the data that I'm showing here is that cortisol has an effect on the physiology of pregnancy. And so it's not only about, if you like, the kind of manifestation of depression, but potentially the consequence of this high level of cortisol can have on the physiology of the pregnancy. And we know that women with depression in pregnancy tend to have a shorter gestational age. They tend to deliver a little bit earlier, and it's possible that some of these biological changes due to the stress participate to that. Now, if you just look at the women with history of depression, but they were not depressed in pregnancy, you can actually see that across all measures of HP axis and cortisol level, there's no difference between the patient and control. So the numbers in the column of the control, the number of the history only are very similar and with no significant difference. So in other words, what these first sets of data show is that if you're depressed, your cortisol level is elevated. But if you have a history of depression and you're not depressed at the time of pregnancy, your cortisol level is normal. And this is important in terms of the effect on the baby. So please keep these results in mind. Now, I'm also very passionate about the immune system and inflammation and how that shape our mental health. This is a much more, if you like, recent area of research that's been developing over the last 10 years in a way that now start having a real translational impact, and there's a lot of people in the research group that work on that area. And so we also measure biomarkers of inflammation, what we call cytokines. For two reasons, really. There are additional biomarkers of stress, so like cortisol, they tend to be higher in situations of stress, but also they can directly affect brain function, and they can induce some of the depressive symptoms. And if you look at the tables, you can see in red that quite a lot of pro-inflammatory cytokines tends to be elevated in the women with depression, what we call here cases, versus the controls. And which is, again, is the same thing that we find in depressed, especially severely depressed people outside pregnancy, but it was nice to confirm it in pregnancy. And at the time that it was published, this was the first study in clinically significant, so women with a clinical diagnosis of depression. Now, what is interesting is that when you compare the women with a history of depression, but not currently depressed, they also have increased inflammation. So you can see in bold the significant p-value across most of some of the cytokines that were elevated also in the women with depression. So you now have a biological system that is abnormal in pregnancy, but is abnormal not only if you are currently depressed, but it's also abnormal if you have a history of depression and you're kind of okay at that time. And again, this is an impact in terms of clinical outcomes, so please keep these findings in mind, and I will go through them once again. We then measure the neurobehavioral response of the babies. And we use the Brazelton test, which is a quite structured way of assessing babies' behavior really early on. And we did this assessment at 4 days postnatally. And as you can see, there's a number of different scales or subscales that are used. And I won't go into a lot of details, but basically it is a way of assessing the baby's response to pretty much stressful situation. There's a researcher they've never met who's there. The baby is exposed to movement, cold, noise, lights, and they respond. And as you can see, across all the 4 scales that are mentioned here, the babies born from mothers who were depressed in pregnancy have lower scores, indicating, broadly speaking, a kind of a more difficult baby, a baby that's that takes more time to soothe, to calm down, and they tend to be hyper-responsive to the interaction with the researchers. And what is interesting is that we found exactly the same things also in the babies born from the mother with that a history of depression, as you can see here, but were not depressed at the time of pregnancy. So there's something that, if you like, remains as a predisposition or as a vulnerability that somehow manifests itself, or at least has some kind of effect of impact in the perinatal period, and downstream from that in the baby's development. Now, we looked at the baby's stress response. How does that impact the babies? And we did a natural experiment. We used the vaccination at 8 weeks as a natural stressors. We knew when the baby were going to be vaccinated. We went to the GP. We sit with the GP, took the saliva from the baby before the vaccination, 20 minutes after the vaccination. Then we looked at the effect. Now, just look at the bottom line for the moment, the continuous line. These are the healthy controls. So the babies born from mother that were not depressed or that did not have any history of depression. And as you can see, there's actually no effect. And this has been replicated quite a lot of times. The babies within the first year of life do not respond biologically to the stress of vaccination. It's just not strong enough. However, if you look at the cortisol levels in the babies born from mother who were depressed in pregnancy, you can see that it goes up from before the vaccination, so before the injection, to 20, 25 minutes after the injection. So the babies born from mothers who were depressed, they tend to have what we define as a hyperactive stress response. The women that had a history of depression but they were not depressed, their baby also didn't show any effect. So you can see the different, it's very difficult to have like a homogeneous or coherent biological picture. Like, there are some biological systems that are obviously acutely sensitive to the current mental state, like cortisol. And the higher level of cortisol in the mothers correlates with the higher level of cortisol in the babies. And then there are other biological systems like inflammation that can be abnormal even in the absence of current mental health difficulties. We then looked at mother-infant interactions. We used the care index, which is a structured it's a structured way of assessing videos of mothers and babies playing together in an unstructured way. And you measure a lot of kind of dimension for that. It's actually an instrument that is routinely used on the mother and baby unit as part of the feedback to the mothers. It's part of the kind of showing improvement and giving, it's kind of part of the therapeutic strategy, if you like, of the mother and baby unit of the Maudsley to use the videos and the care index as a way of assessing the mother-infant interaction. But we did that for kind of research purpose. And we did it both 8 weeks and 12 months. And we were quite surprised in a way from these findings. Now, I'm just going to ask you to concentrate on the 3 column on the left, the one that are called dyadic synchrony. That's a measure. As you can see, there's multiple measures you can extract from the care index, which is basically around how the mother and the baby interact with each other, how the mothers respond to the baby's cue, how does the baby respond to the mother's cue, how they look at each other, how they smile in synchrony or not. The dyadic synchrony is a measure of how much the alignment between the mother and the baby in their interaction. And as you can see, compared to the healthy mothers and diet, so the black column, both the mother with a history of depression, which is the light gray column in the middle, and the mother with a current depression with the depression in pregnancy, which is the kind of darker gray, they both have reduced dyadic synchrony. So they have some difficulties in the interaction. Now, let me qualify these findings. None of the level of the difference or the disturbance that we see in the mother-infant interaction met other concerns for care or a clinical threshold that would require kind of concerns about the mothers. So these are small differences that nevertheless are important from a mechanistic point of view, especially the fact that women with a history of depression that do not have current depression, who have not been depressed over the last few weeks or months, still have some difficulties in developing this interaction with the babies, possibly because of kind of difficulty that comes from the kind of the, in general, from the kind of the weeks and the months during which attachment is naturally formed. And of course, that's, so there's one message here is how we can help all women with mental health difficulties, even if they're past mental health difficulties and they're currently well when they are in the perinatal period, because they are, they could be as vulnerable or at least have some vulnerabilities. And we found exactly the same things when we repeated at 12 months. I mean, it's interesting that if you just look at the numbers, it goes up from, 4 to 6, it goes up on average 4 to 6 to kind of 6 to 8. So just with time, everybody improves. And you would imagine that, you spend now 12 months with your baby, obviously your interaction will be better. So everybody improves. But there's still this subtle difference between the healthy mothers, or the mother with no mental health difficulties, and the mother with the history and the mother with depression. So if I want to kind of bring all of this together in a kind of, if you like, biopsychosocial models, definitely with acute depression in pregnancy, there is an increased cortisol in the mothers, and there's also an increased cortisol response. So these are, if you like, there's an element of priming so that the elevated level of cortisol somehow signal to the babies to develop or to a hyperactive stress response, so that then the babies also tend to respond more, in this case, to the stress of vaccination. Well, if you just have a history of depression, luckily you don't have any abnormality in your cortisol, you don't have any abnormality and the babies don't have an abnormality in the cortisol response. However, the inflammation, which, as you said, over the last few years has been considered one of the key pathogenetic mechanisms in mental health, and a direct body-to-brain communication system. A signal originates in the blood but can influence brain function. That is abnormal both in the mother who are depressed and in the mother who have a history of depression. In the same way, the neurobehavioral response in babies is similarly different in the mother with both a history of depression and acute depression. And the mother-infant interaction is also disrupted both in the mother-infant, in the history, women with a history of depression, and the women with acute depression. So there's something about the biology of, if you like, a lifelong mental health or depression vulnerability that perhaps through an immune or inflammatory mechanisms also affect pregnancy and the development of the babies. And we now know from some unpublished data following up the children of these mothers that some of it, not obviously in a deterministic way, but just as an increased risk, some of this kind of risk or some of this vulnerability that we saw in the immediate postpartum is still present when we follow up the kids at the age 7 to 9. There's a couple of points I want to make. These are unpublished data. First of all, if you just look at the maternal mental health, so if we measure BDI in the mothers, and this is just like a random back depression inventory, a random assessment of depressive symptoms on one day where we did the follow-up. So it's not that the mothers were acutely depressed or we looked for them because we knew that they were in a particularly difficult phase. Yet they have higher level of depressive symptoms compared to mothers that were not depressed in pregnancy. So even 7, 8, or 9 years later, on a random day, the mother who were depressed in pregnancy have higher level of depressive symptoms compared to the mother that were not. They're not clinically significant level of depression. They're below, even if you consider kind of 8, the average of 8 or the highest level, kind of 10 to 12 in that group, is still at the threshold of a significant depression, but nevertheless, it shows some kind of, as I've been saying, a trajectory. A vulnerability is perhaps pre-existing to the perinatal period and continuing after the perinatal period. In the children, they have a kind of a mixed, if you like, impact. If you assess their mental state using questionnaires that they themselves completed, the DCRS-C and the STI for depressive symptoms and anxiety symptoms, there's actually not different. There are no differences between the babies born from depressed mother and the babies born from healthy controls. We didn't have the women with a history of depression at the follow-up. So there's no difference. However, we also knew clinically that 23% of children born from mother with depression had by then, so around age 8, be seen by or been in contact with CAM services compared to 8% of children in a control group. So again, a trajectory of vulnerability. I mean, the flip side, you can say that, more than close to 80% of the kids born from mothers who were depressed in pregnancy didn't have any contact with mental health services. So, it's not, as I said, it's not deterministic, but it's an increased vulnerability that we need to be aware of. And similarly, we found subtle difficulties in the communication between them, in the attachment between the mother and the child. Now, we now measure attachment. The children are much they're older. You can actually look at the attachment style. Some of you may recognize the names of the attachment as is normally described. So secure attachment is an attachment where the baby feels comfortable in their relationship with their parents. They feel that the parents as the main, usually the mother as the main caregiver, they feel safe with the mother. They will feel that the mothers will always be there for them. Insecurity is when the attachment style becomes more complex. Perhaps the baby tends to be more distressed, in a classical construct is about the babies feel more easily distressed by the absence of the caregivers and being either upset or what we call disorganized, which is really kind of unpredictable in the response to separation. And as you can see, there are subtle differences between the babies born from the control group in dark green and the babies born from the depressed group in the lighter green. So the difficulties in mother-infant interaction continues and is still present in the follow-up. These are unpublished data. We just now finished the complete follow-up. Now, we've talked about depression in pregnancy. What about postnatal depression? And I want to finish the talk by saying what we can do about perinatal mental health difficulties, not only about, what are the consequences, what, if you like, is what are the risks and that we need to be aware of, but also what can we do to change this trajectory, to properly change this trajectory. And I want to talk about the work that we've been doing in postnatal depression in collaboration with Breathe Heart Health Organization in the Melodies for Moms study. So this is a study where we tested a psychosocial intervention centered around singing groups for women with postnatal depression. So women had either depressive symptoms, clinically significant with the EPDS score, which is a standard way of measuring depressive symptoms in the perinatal period above 10. Not all of them, but most of them also had a clinical diagnosis of depression in the postnatal period. Some of them were referred by services, including from the perinatal services from the Maudsley. These were all women from Southeast London. Some of them were self-referred through social media. Some were referred by primary care. So it's like a mixed level of severity. And the group is kind of built around 12 to 15 women with their babies, as you can see in this picture, spending 1 hour a week together with an artist and kind of singing together. Now, there's nothing I can tell you that will make you feel the experience of actually being there, so I'm going to show you a video.
Is an evidence-based group singing intervention that works with mothers with symptoms of postnatal depression. In just 10 weeks, we can show that our bespoke singing intervention can reduce symptoms of postnatal depression and improve mother-infant bonding.
For me, the way that anxiety manifests is that I just have reoccurring thoughts. What if this goes bad? What if this goes bad? And while you're singing, those thoughts just stop,
coming stressed and leaving as if we'd almost sung our stresses out.
There are many barriers to mothers accessing traditional healthcare services when they're struggling with postnatal depression. We really pride ourselves on creating an inclusive and safe environment. We sing songs in multiple languages and from different cultures and countries, which creates a sense of connection and community.
It celebrates community, and sometimes in motherhood, we only think that community is for our children, but community is for the mother, because if the mother is whole, she can give a whole and a great experience for her child.
It's not your usual mum and baby group. It's strictly a nursery rhyme-free zone. We don't talk about postnatal depression at all in the sessions, but the programme has been intricately designed to meet the mother's very specific needs.
Just a place to learn some techniques of just relaxing body and mind, and also just taking time with the baby, but knowing it's for you. I think that's quite nice.
I'm a single parent, and sometimes it can get quite overwhelming and stressful. It's helped me be more confident.
From Breathe, the moms, the families have felt confident to come in and access further sessions within the children and family centres up until their child's reaching nursery age, which has been quite phenomenal.
We follow approximately 200 women throughout 10 weeks of intervention, and then we saw them again 6 months after the end of treatment. What we found is an improvement in the depressive symptoms that was sustained 6 months after the end. The fact that the improvement was still sustained is really new and, of course, very clinically important. We measured cortisol in the saliva. Cortisol is the main hormone that expresses how stressful people feel. What we noticed is that women had a drop in cortisol. We were also able to measure the cortisol levels in the babies. And what we found, which is really interesting, is that the level of cortisol in the mothers and in the babies tend to synchronize as the time goes. It's a biological manifestation of the improved mother-infant interaction.
There's plenty of research to show that interaction in the perinatal period sets the foundation for the infant's development throughout the rest of life. As our results do show that the mum is more in tune with the baby, and these mums can have downstream positive impacts on the baby's development through the rest of their life.
Melody for moms is really cost effective. The mothers gain the equivalent of 15 days in full health for a cost that is lower or comparable to a lot of other community-based intervention for postnatal depression. So truly a great investment.
We want this programme to benefit as many mothers, fathers, parents and wider communities as possible. So we can deliver programmes online, and our research has shown that the programme can be just as effective delivering it as an online intervention. We're now piloting this work with dads and fathers. We're now also partnering with the World Health Organization, training teams to deliver this all over Europe. So we hope that through having designed and delivered this intervention for now over 7 years, it can be a new way of delivering postnatal depression services across our community.
And I have one more video, so. So this is, as I said, is a study that we conducted in collaboration with UCL, and of course, Breathe Heart Health Organization is quite embedded within the Southeast, along kind of the Southeast area, the area that the Maudsley covered, and they also had a period within the mother and baby unit. So it's a service that, as much as possible, we're trying to kind of bring into kind of the routine or the standard of care for women with postnatal depression. I think it's important to notice that postnatal depression, the prevalence of postnatal depression is rising. And if you look at the data over the last 10 years, there was obviously a peak after COVID. And everybody says, okay, it's COVID. But if you look at the trajectory, There was already an increase before COVID. And I think that it shows one more time, if we didn't have if we didn't know that already, that the women in the perinatal period are the most vulnerable members, or among the most vulnerable members in the community. When a society suffers, like, you know, the kind of British or Europe, kind of in general, Western society is suffering over the last few years with kind of financial difficulties and kind of lack of social support and lack of financial support. I think the mothers, or the mothers in the perinatal period are the kind of the ones that first showed that vulnerability at a societal level. So I think I'm not surprised that with all the difficulties in the societies, as we're seeing the increase in mental health problems in childhood and adolescence, we also see that in the perinatal period. So it's great that we have an opportunity to deliver one intervention in parallel with so many that, of course, we know are effective, like antidepressant or psychological intervention, using a psychosocial approach. And the effect, as was mentioned in the video, are clinically significant. So these are the depressive symptoms measured with EPDS from the beginning of the trial until up to 36-week follow-up. So that's 6 months after the end of the intervention. The intervention is only 10 weeks. The black line is the singing group. The lighter line is the control. So women that were randomized to attending local mother and baby groups, but not the specific singing intervention. And as you can see, there's like a rapid drop in depressive symptoms, a faster drop in depressive symptoms, black line in the group, the women doing the singing intervention already by week 10, which is when the intervention stops. But then the difference between the two groups continues and gets even bigger by week 20 and week 36. So it's a persistent effect, which we think is also about, as I will show you in a second, about giving mothers skills to use singing beyond the 10 weeks of the intervention as a way of kind of improving the interaction with the babies and maybe calming the baby or kind of calming themselves, or kind of, so kind of use the singing as a therapeutic tool that goes beyond just the intervention. We looked at mother-infant communication again. In this case, we used the mentalization construct, so the fact that, again, you record videos of the mother and the baby playing together, and you score, or you rate how the mother talked to the baby, and you rate how much of the thoughts, how much of the kind of the way the mother talked to the baby reflect an understanding of the baby as a mindful being, human being, and how much of these thoughts are directed, kind of caring for the baby. And so if you look at what we call mentalizing comments, so the comments that consider the baby as a kind of as a human being with a mind, if you like, you can see that from the baseline to week 10, so the end of the singing intervention, there's an increase in the singing group with the dark, which is the black line, compared to the control. And again, this is maintained 6 months later. So a persistent effect, perhaps explaining why also the effect on the depressive symptoms continues for such a long time. And the parent-focused speech, so the mother talking about, if you like, herself rather than about the baby, drops. So now you can see that the singing group, the black line is going down, and the control is going up. So these are, if you like, the thoughts that are not directed toward the baby, more focused on the mother. These tends to diminish it. So that's all manifestation of improvability or improved kind of way of thinking about the baby and communicating better with the baby. And again, this was mentioned in the videos. Cortisol levels goes down only in the mothers that do the singing intervention. If you look at the first set of graphs on the left, this is the cortisol level. Remember, we can measure, cortisol is measured in the saliva, so it's very easy to do. So when mothers came in for the first session, week 1, they took the cortisol before starting the singing intervention, pre-session, then they took it after the session, the post-session, and you can see there's a drop. Now, in the first session, there's a drop both in the singing group, which are the darker column, and in the control group, which are the striped columns. However, at week 10, so after the women had 10 sessions, only the singing still has a really this decreasing cortisol effect, so this anti-stress effect. Control group they do no longer experience this kind of calming effect of being in a therapeutic environment. As I said, the control group were attending mother and babies group, not dedicated to singing though. And very similar with inflammation, very similar signal. You can see a drop of IL-6, TNF-alpha, these are the two of the most important biomarkers of inflammation. You can see a drop between pre-session and post-session in the singing group, the darker columns, but not in the stripe. So there's something about singing that has an enduring effect in terms of symptoms, mother-infant interaction, biological stress response. And of course, singing has been so fundamental in many cultures. And mother and baby singing together, or mother singing to the babies, has been part of a culture of kind of caring for children. And this is just one way that we've been able to assess that in a structured way. The video also refers to online. During COVID, we started studying COVID, before COVID, then we had to stop for COVID. So we immediately switched the program online. And now, because it's been successful, they actually deliver it online for women that are not in the area or cannot attend physically. And we also show similar efficacy in the online group. And this is just the second video I wanted to show you, because it's equally nice and interesting.
I was a first-time mum and everything was just changing and I just didn't know what was going on with me. I was really high and then sometimes I was low. But when I went to these sessions, I found myself again. I realised how important I am.
I joined Melodies for Mums because I was really struggling when I was first born. And at the advice of my health visitor, she said, maybe you should try this. And I joined and it was the best decision that I have made.
Starting the week with something so positive is really lovely. My husband is around at the weekend to help and that's really nice. And then you start the Monday just thinking, oh gosh, I've got another 5 days. I mean, I love Teddy's piece, but looking after a baby on your own is tired. So starting the week on a positive note has made a big difference to me.
Being a mom could be lonely at normal times. During COVID-19, this is amplified.
This is a very, very isolating job and it's been made even more isolating because of the pandemic. And it's so great to be able to be part of a community and see everybody and see other babies, see other mums and just don't feel so alone.
The babies were there as the extra benefit, but it was the mums, the focus was on them and just for them to realise how important they are.
It's the opportunity to get together with other moms and do something together.
This has shown me other people and made me feel connected again.
I just always feel really good afterwards.
We had such a great music leader and the rest of the team was so supportive. It was important to have that safe space, really important.
The thing that I enjoy most about Melodies for Mum is learning different songs every week, so it's not the usual nursery rhymes.
We learn so many lovely songs and we sing them all week long, so it keeps us going.
Teddy really responds to the songs. We use them a lot in our everyday kind of interaction. So it's nice to just have another tool to use in terms of communicating with your baby.
Melodies for Mums is a way for us to reconnect with ourselves, with our babies and with others.
We have been doing Melodies for Mums every Monday morning and it's something that we look forward to so much.
And as I've said, we did evaluate and publish this data with a single group, not randomized, but you can see a nice drop in the depressive symptoms, and with average level quite high. So you can see how postnatal depression during COVID was really kind of impacting clinically. and the level dropping already by week 3 and then continue to drop by week 6. This time was under 6 weeks intervention. We didn't want to have women online for 10 weeks. We thought they would not engage for such a long period of time. But you can see that then they remain, with lower depressive symptoms up to week 32. So kind of really evidence that this intervention can work. So you can see that now we have the possibility of doing something that changed vulnerability, changed lifelong vulnerability, changed trajectory, changed transgenerational trajectory. Epidemiological studies has shown and will continue to show a relationship between maternal mental health difficulties and next generation mental health difficulties. And we did this study in the Auspach court a few years ago, where we map it out completely, and it's a complicated slide. I won't go into the details because so many people and so many studies have shown exactly the same thing. But what I want you to notice is that you start with a difficult a difficult childhood in the mothers, here characterized as childhood maltreatment in the mothers. You go all the way to internalizing and externalizing problems in the children of those mothers. So 30 years later, if you like, you have the effect, you have like this kind of transgenerational effect. And within that pathway, there is everything that we've discussed. There's depression in pregnancy, there's depression there's difficulties in the childhood, experience, maternal postnatal depression. However, the map, the vulnerability has been mapped. But what we can do now, that we know that we can intervene, we know we can find these mothers, we know we can convince to engage with treatment, we can offer them care as our Maudsley Mother and Baby Unit and Mother and Baby Services do, that we can break this transgenerational transmission. We can really stop it, and then the next generation will all be like this, children's mommy. Thank you very much for your attention.
Okay, everyone, so I'm Derek Trace. I'm the Chief Medical Officer at SLAM and Adjunct Professor at the IPPN. What we're going to do is we're going to Q&A for a while, and then we're going to invite you, if you have time, to join us for a drink and some food upstairs. I just want to note, I know we've had some problems for folk online. Some of the streaming has been a bit intermittent, but the recording will be available afterwards. So our comms team, they've got Maudsley Talks t-shirts. They're going to go around with mics. If I could ask you to wait till the mic gets to you, and if you're happy to, tell us who you are, where you work or what you do, and then if you want to address your questions coming in. Any hands? Let's get the mic down to you here.
Yeah, I think you've been doing a great job. Fascinating.
Thank you.
My name is Kola Abiola. I work in the crime industry. The cortisol experiment has been a great experiment. Like I said, I work in the crime industry. From the aspect of my profession, I make an observation, then I can come up with a question at the end of my observation. Now, one thing that I keep asking in my head during the presentation was that in criminology, I had my first degree in criminology before my master's in crime science and security. We are very much concerned about the what we call the neurotransmitters. The neurotransmitters, there are three sets of neurotransmitters that we look at. We have dopamine, neuropeptide, and serotonin. We notice that if it's in short, serotonin in particular, there is the tendency for depression And dopamine is a reward kind of stimulant, right? Now, I haven't seen that in the experiment, how you're able to link. Perhaps it's not necessary. I'm just wondering, perhaps that might help to improve the experiment in the future along the line. Now, serotonin, we find out that diet can also improve health if you take specific or certain types of diet, certain types of nutrition. Perhaps that might also help to, because when serotonin is low in the body, it causes depression. Because it's a type of chemical in the system, as you know, that processes information before it sends this information throughout the body. And why we have this automated or automative system functioning of the body organs.
Would you like to ask me a question, Tom?
Yeah, my question, I'm just, this is my observation actually. And my question will be, because we've been here for 1970 something, it's over 20 years actually. I'm just wondering, how many clients would you say over the 20 years period of time, how often do you have to deal with this postnatal depression, depression during pregnancy, the volume of your patient? Is it increasing or either decreasing over the past 20 years, so we can see how much this experiment might be valuable now and in the future?
Thank you. It's a very good question. And I mean, there are many people here who can talk about the prevalence of perinatal mental health disorders, and certainly frontline staff, they're seeing the impact of that in terms of women asking for care. But we definitely know that the prevalence of all mental disorders in the perinatal period is increasing. And there was a survey done, published 2 or 3 years ago, that showed there was an increase that started already before COVID, so about 10 years ago. And then after COVID, there's been another peak. So I think all the epidemiological data show there's an increase in perinatal mental health problems. Whether it mirrors of kind of the general difficulty with mental health in the society at the moment, we know there are other vulnerable groups, children, adolescents. However, I will repeat what I really want to emphasize before, which I think it is, women in the perinatal period, they are among the most vulnerable in the society. So I'm not surprised that when society is struggling, women in the perinatal period struggle first, and they are the ones that we're seeing. Yeah. So going up.
Thank you.
Thank you.
Right, we've got a question here.
Thank you. That was fantastic. Thank you.
Thank you.
I was wondering if you have looked at the efficacy of the singing intervention in non-mothers, in other people who are depressed, just as a maybe not you personally, obviously, but yeah.
I have not done it. There have been other research showing, in general, that singing has, improving the mood, improves the feeling of social connection. There have been other studies showing that singing decreased cortisol in other population, increased oxytocin. So I think the therapeutic effect has been quite established. There have not been many randomized control trials. In fact, I think this is the only randomized control trial in any kind of proper mental health indication. There are more studies around stress levels and well-being. But yeah, we know it works.
Thank you.
Thank you.
Thank you very much for the talk. It was brilliant. I just wanted to ask you, so have there been any barriers when you're trying to get South Asian women to access this, or other sort of smaller minorities? And have you, or would you be interested to try it in different languages and communities where there's a denser population?
Yes, so obviously we invested so much in the singing intervention because we feel that it's kind of less stigmatizing for women to attend. As Yvonne, that you heard in the video, which is the chair of the arts organization, says, we don't really talk about postnatal depression. The recruiting material is all about, are you struggling with looking after your baby, or, is it a really difficult time postnatal, and so on. And I think that helped women with really kind of a variety of background. And we do have, you've probably seen the picture in the video, we kind of quite mixed background. I mean, it'll be interesting to see if we're missing particular group of women that we haven't been able to access to, and maybe do some work specifically with that. We have not been able to do such a kind of a direct assessment. Yeah, thank you.
Hi. Sorry, I'm here. I'm interested in the intervention and the singing intervention, and to understand kind of the mother and infant interaction, and how kind of you could distill it, or thinking about what happens between the mum and baby. So you have voice, you maybe have touch, you maybe have more eye contact. What would you be observing? I mean, you mentioned singing is, part of social connection, but what would I see in the room, or, look for?
I think all of the above. I mean, we specifically measured verbal communication in this case, and we kind of know, I think, what mothers do, they develop what we call momentalization. So they kind of become more aware of the baby's having a mind, having psychological processes, and responding and proposing emotion, responding emotion. And I think maybe it's, it could be so many things. It could be the fact that they spend more, they sing to the baby responds to the singing, then they go home and they continue to sing to the baby responds. So they just spend more time together in a pleasant activity, and the mother notices more the feedback from the baby, and so she becomes more aware of the baby. I think it's one of those complex things that there are so many positive, if you like, aspects that connect together. I think also in this case, the fact that they spend, 1 hour a week with other mothers, with other babies, so they also kind of, there's a social connection between the mothers. They're always the same mother, so for those 10 weeks, there's the same group. So there's many, if you like, active ingredients that could really help. Thank you.
Good question.
Hi, thank you.
Thank you.
Very good presentation. I just wondered, did the study results differ for younger pregnant women in comparison to the mature pregnant mother?
No, so it's a really good question. We looked at that in particular because we wanted to see at age as a vulnerability factor, and we found that was equal effect in mothers below the age of 30 and above the age of 30. So I think from that point of view, again, because it's so kind of, if you like, cultural, and it's not linked to a particular way of approaching the problems or discussing about the issues, much more kind of, at a kind of primordial level, if you like, a visceral level. But yeah, we found it working both, which I think is really important because, of course, we also know the younger mothers are more at risk of postnatal depression, so they're even the most vulnerable within the vulnerable group. Yeah, absolutely.
Hello, I'm Gordon Kay, Director of Research at Public Voice, which is a community research organisation, and I just wondered whether you'd considered any qualitative studies, particularly about the access to these services and the experience, because clearly it's there in the videos, but in that respect, and also maybe the sense of community that also comes out of bringing people together through singing, and whether those relationships carry on beyond the trial.
So as part of the study, we did have some focus group and some interview and qualitative work. It was led by UCL. So it's kind of, I haven't presented here, from Daisy Fancourt, which is kind of PI from UCL, who's also done a lot of work in this Melodies for Moms and the kind of singing intervention sphere. And so she did the focus group, and she did a kind of evaluation of the women experience. And I think a lot of it was about the social connection and the feeling of being, with women that were similar to them, as in all having the same level of difficulty, so a feeling of kind of normalization of what they thought was only their experience, noticing this is actually much more common, the support, the network, and so that's one active ingredient. And then I think they also talk a lot about the singing at home, so they bring in the skills that they learn in 1 hour, they bring it at home. It's not just something they learn and they use it there. So these are the two main elements from the focus group.
Okay. Thank you.
Good evening. Sorry, I'm a pediatric nurse actually working in King's College Hospital. My question would be, would it be quite useful to do information markers already in antenatal a meeting, you know, when they see midwives, for example, because the inflammation markers could be depression, could be all sorts of other things. Would that be useful to do it already from kind of when mothers see midwives and kind of going on through?
Yeah, it's a really interesting question. I think we're struggling at the moment how to best use the information we have about the inflammation in mental health, and whether, you know, how much kind of would be important for, you know, routine assessment or screening. I think at the moment we're still at the research level, that none of that can be immediately translatable from a clinical point of view. But, you know, it gives us a theoretical framework. And so, for example, you know, interventions that are naturally anti-inflammatory, I think about diet intervention, our colleagues talked about diet intervention before, you know, nutrition intervention that are available in pregnancy, physical exercise that is, you know, within the limits of kind of what can be done in pregnancy. All this anti-inflammatory strategy that probably could have a therapeutic effect beyond, you know, just the psychological effect, if you like. Yeah.
Thank you so much for your talk. I actually work within one of the community mental health teams and have a background in children's social work. So I've actually worked with a perinatal team. So this is actually something that I'm really, really passionate about. I guess I'm very curious about the focus group. And I know one of the ladies over there touched on, you know, the demographics and the different cultures that we had within there. And I guess one thing that I'm quite curious about right now when I look at different studies is around women who are married or have partners and mothers who are single, and I guess the impact of those differences, and I guess their cultural, the cross as well of the cultural background, right? How that stress may impact their pregnancy and their pregnancy journey. I don't know if there's a question in there, but I just thought I would bring it to you.
Yeah. No,
Thank you.
We knew, obviously we know from kind of case control studies that mothers who are single or that are unsupported either in pregnancy or postnatally are more at risk of developing depression. And I think we did find quite I don't remember the exact number, we found, I think, close to half, if not more than half of the women in our group with postnatal depression were either single or kind of without a partner. We didn't have the numbers to look at whether that was a factor that particularly kind of, it didn't come up as a factor that would either prevent the therapeutic effect or, because you know, it's very much about the mother and the baby interaction. As Yvonne said in the video, we are actually started doing some groups with fathers with what we call postnatal depression. So fathers who are struggling in the perinatal period, the singing intervention, very similar structure. We're just starting now, and so, you know, it'd be nice to see how what's their kind of take on kind of the response to that. Yeah.
Thanks very much. Hi, Carmine. Thanks so much for the lecture. I wonder if you could comment a little bit on sort of moving away from the category of depression, either depression or history of depression and control, to a more kind of public health question. You know, what are the ramifications of your research, or what are your thoughts on what should be general public health guidance for pregnancy, based on what you know, not just for people who either in pregnancy or postnatally develop depression?
Yeah, you're kind of, you're asking for the politician in me to kind of. So, I mean, I think, you know, it'd be great if women in pregnancy have a house, all of them have a house, have a safe bed, have a, you know, they could eat, they're not, locked up somewhere. I mean, I think, that's public health as well. I think that's why I think that a society that doesn't look after pregnant women or women in the perinatal period is not looking after the next generation. So that's my first comment to that. But in terms of public health, I know this is not public health, technically speaking, but I think it's important. I think social support, and so what obviously the singing intervention does is capitalize on creating social support between mothers, social support from the, between the mother and the baby. And I think anything that can do that, and if there's a way of doing this, for example, online, so the way they kind of bring this not this intervention, a similar, an approach that improve social cohesion, social connection, and social support to an individual level, whether it's just online if it's not possible to do in person. So that there's something around the perinatal period that really benefits from. Obviously, we know the whole mental health any time will benefit from that, but I think there's something about the perinatal period where the isolation is more. It becomes more like a a regular experience for a woman, for many reasons. I think that's possibly the first things to do from a public health point of view. Yeah.
I've identified 4 more speakers. There will be time afterwards to ask questions too. Sean, do you want to
Oh, hello. Thank you very much for your talk. I just wanted to say it's just clarified a lot of things that have happened to me in my life. I had a very traumatic delivery of my 4th child, and I was 37, so I was a lot older when I had younger when I had my other children. I work at the Islam Recovery College as a peer trainer, so I support a lot of people to move forward in their life because of my lived experience. But I'd just like to talk about singing, because it completely changed my life when I started the Mind and Soul Community Choir in the Maudsley Hospital in 2008. And when I started at first, I couldn't even sing. I think I was depressed and I was going through a divorce. So I just used to sit and listen for about 5 or 6 weeks. But what I'd like to say is that, I've kept up the singing. I'm now singing in 3 choirs, and I'm doing solo performances as well. And through the singing, it's really helped me in my recovery journey. And I always advocate singing to all my students. And most of them go along to the Mind and Soul Choir. It's made up of service users, carers, and their supporters. And talking about the social connection, it's really helped everybody move forward because we have social events together. And yeah, I just want to talk about the benefits of singing. And thank you for highlighting that.
Thank you.
Thank you so much for the wonderful presentation. It was very insightful. I was very curious about the psychosocial intervention that we talked about. Could you please elaborate how you'd mentioned that the mothers experienced reduced parent-focused speech, if I'm right, and also the aspect about how they've started to think of the baby as an intellectual being with its own thoughts. Could you elaborate how that could, the mechanisms, if I may, to sort of build on their question, how it can reduce with the depressive
It's a little bit like we were discussing with the other question before. So I think, what we call parent-focused speech is when the mother talks to the baby about herself, if you like, rather than about the baby. Okay. Which, there's nothing wrong. I'm not saying the mother should not talk about themselves to the baby, but it's kind of there's, as always, there's like a spectrum, and the more the mothers kind of alternate between thoughts about herself and thoughts about the baby, or talking to the baby about how the baby feels or what this baby wants, then it kind of shows, it kind of goes hands in hands with the ability to then look after the baby and caring for the baby, and also understanding the baby as a, as I said, as like a human being with their own mind and volition and decision, if you like, and I think that again increased the connection because they kind of they feel that they got constant feedback from the baby. I think the mechanisms are complicated. There are mixes. Some of it will be the time spent together. Some of it will be the singing that creates positive vibes and more smiles than maybe if the baby was just on his own playing or left like looking at the video or something. Some of it could be, the reduction of the stress in the mothers, so that the mothers, perhaps is less aroused, less anxious, could concentrate more. The baby, we know, I haven't showed the data, but the baby cortisol level goes down, so the baby will be calmer, less stressed, maybe more able to kind of interact positively with the mother. So it's, there's so many things operating at the same time. Yeah.
We have 2 more questions from there.
Yes, my name's Jonathan Ness. I'm a corporate financier and lawyer by background, but I spent 15 years trying to raise awareness of stigma of mental health in the workplace. I'm shocked that actually, there hasn't been a RCT done on singing for adults. And since I'm inviting you to be a politician, there's a lot of appetite for more information here around how this works, and also interest in people. Perhaps we'll all be phoning our local choir to see where we can engage. What is the answer to getting gold standard RCTs on psychosocial interventions when there aren't clearly pharmaceutical outcomes which can make money for the companies that will fund the research?
Yes, of course. I mean, look, there is a lot of interest, and if anything, the UK is leading the world in terms of what is broadly called social prescribing. So, the things that tap into psychosocial intervention, creative intervention, cultural art, nature, and how that could be embedded within the NHS, usually kind of through primary care. And I think a lot of that is available or for prescription based on, I guess where is your postcode or what does your GP do? And I think, there is evidence. It's not that there's no, randomized controlled trial, but I think, ours was one of the most robust in terms of proper randomization. And I think it's difficult to, what do you compare? So there's methodological difficulties, do you compare singing versus nothing, or do you compare singing versus, you bring people together to chat? So there's kind of methodological difficulties sometimes. I think that, there are two, we're actually we're doing this reasoning now, trying to bring the singing intervention more into mainstream, if you like, NHS adoption everywhere. And I think, first off, you have to show that it's effective. Then you have to show it's effective in a variety of cultural, geographical context, different area of the country, for example, rural versus inner cities, different ethnicity, different culture. And I think we're all in the right direction with that, with the singing. And then you have to demonstrate this is cost effective, so it's going to be cheaper than, let's say, an equivalent, for example, group psychological intervention that at least the same cost. Because then, of course, women have a choice, because not all women may want to go to a psychotherapy group. They may want to go to singing and so on. So I think these are you show that they're equally effective, you show they're cost effective. And at the beginning, we'll have to be funded by research entities, so we were funded by the Wellcome Trust. And then you hope that you create enough evidence that the NICE approves it as a evidence-based treatment, and then the NHS follow. But yeah, you do require the money from our research funders, at least initially.
Last word to Nozomi. Do you want to get the mic down here? Nozomi?
That's a really good question. Just on then expanding this, I'm a community psychiatrist and medical manager, and with the spirit of this great, lecture series and the first one for greater collaboration between the clinical community and the academic community, what would be the next step to expand further? Because I'm really pleased to see our academic colleagues are adding solid evidence of psychosocial, inclusive, and culturally adaptable intervention to help the population. And this is another piece of evidence that if we invest small amount of money even to the maternal mental health, we are going to save much, much bigger population for the future generations. So what would be the next step we can influence the direction of the journey locally and regionally and nationally together? What's your view on that?
Thank you. I mean, it's really good questions. I mean, look, I think that if there's one thing that this study shows, that actually, academics, clinicians, within the Maudsley, because basically all of the women were either already with the Maudsley perinatal services, or were in the catchment area of the Maudsley perinatal services, which means we could go to the Maudsley, we could refer them if we were concerned. So I think that kind of collaboration works in the delivery of the evidence. And then once you have the evidence, then you have to try to bring it into the services. And, truly brought the Melodies for Moms to the Mother and Baby Unit. There was, one opportunity. We're doing an assessment. I think if it shows the data we hope to show, then you have a cost-effectiveness kind of case to bring it back. So I think it's a mixture of creating the evidence, working together, facilitating the recruitment, and then kind of convince the NHS, the local trust, or the kind of commissioners that that's the type of intervention you can bring.
I'm not sure who's got to speak for the local trust, but what I'll do is I'm going to bring it to a close there, but if I could ask you to say thank you again, Professor Carmine Pariante. So a couple of quick final things. Can we get the next slide up? Is that on here? So just to say about our next talk. So our next talk, we're going to alternate the series with hybrid, as was today. Again, we had some gremlins with the IT, but the recording will be available. We're going to do a hybrid like this, where you can come in or go online, and then online only. The next one's online only. So the President of the Royal College and one of our consultants here, Dr. Lade Smith, how to ensure your child does not become one of my patients. That's not just how not to become one of Lade's patients, that's a patient in mental health services more generally. So we hope you can join us for that. I want to say thanks very briefly. I want to thank our friends and colleagues in the IOPPN. It's been said lots of times tonight, so many of us work across both. I always say that the greatness of SLAM is through the IOPPN, but the greatness of the IOPPN is through SLAM. It's when they come together, it's really, really special. So thank you to colleagues from the IOPPN. Huge thank you from me to Chris Davies and colleagues from COMS. It's been fantastic having you help us organise this. So I hope you can come join us. We're going to, if you follow people in T-shirts that say Maudsley Talks, they'll take you upstairs if you'd like to have a glass of wine or a soft drink or some food. It'd be a pleasure to have you with us. Thank you, and we'll close the night.